Okay. Um, Thanks everybody for coming. Late Monday time slot here, but thanks for coming. And this is being live streamed to what I've heard is millions of people across the world right now. So um, don't worry that if you're not here in person, you'll definitely still get the full effect of the course. There's a couple of housekeeping things we've got to talk about before we start. This course utilizes the audience response questions to participate. We'll give you some instructions on how to use it as we go. The AUA 2002 annual meeting app is available and free to download. Use your email to register, and your password is your AUA ID. So I'm Tom J-Ram. I'm joined here by two friends and colleagues, Dr. Gordon Brown and Dr. Neil Shore. And the topic today is immunotherapy in urologic practice and how to operationalize it and kind of how to bring it more internally and towards urologist practices. So we're going to spend some time talking about kind of three topics on what we think is kind of an important part of the strategy here. So the policy for the AUA is that we all disclose prior to our presentation all financial relationships, and that those will be disclosed. Please remember to silence your cell phone. No photos, video, or audio recordings are permitted. And the evaluation results at the end of the course are important because the courses are graded and selected based on those, so please keep that in mind. And if you complete a course evaluation, you will be entered into a drawing for a complimentary registration for next year's course. So, and at the end of the course, there is a post-test, which we take very seriously. And as part of our educational outcomes research, you'll receive an evaluation survey and a post-test. And completing this is required to claim credit for the course. Everyone who completes this will be entered for a Visa gift card drawing. Okay, terrific. So, again, operationalizing immunotherapy in urologic practice. The three of us all have, I would say, significant experience in this topic, and I think you're going to hear some interesting anecdotes, stories about how we have done this, what we perceive to be the benefits, what we can do better, and really how to bring this closer to home and more centrally tuned for our patients. So here are our faculty disclosures. These are on the AUA website as well. So again, three kind of big pieces that we're going to talk about. Dr. Shore is going to start by talking about the relevance and the utilization of checkpoint inhibitors in urologic oncology and kind of where we are with the science and the data today. Dr. Brown is going to talk about kind of the practice implications of implementing a checkpoint inhibitor program, the structure, kind of what it takes, how to implement it. And then the last part, I'm going to conclude by talking about kind of the efficacy and the safety part of it, how to manage adverse events from checkpoint inhibitors as part of kind of a structured program. So we do want this to be interactive. Obviously, there's microphones down the middle of the aisle. Any questions? And let's keep this fun and loose and just kind of hang out. So I'm gonna give this to Dr. Shore. He's gonna. I think we can probably all do this from our seats. If you can't hear us, let us know.
Well, thanks very much, Tom, and thank you so much for your initiative to do this course and asking myself and Gordon here to be part of it with you. As you've pointed out, there's my task will be talking about the relevance and utilization. And I think as all of us who are uro-oncologists and in large practices, and when I say a large practice, I think that includes academic as well as community practices. And in 2016, when we saw the first approval of a checkpoint inhibitor, PD blocker, bringing in this notion of a different mechanism of action, novel mechanism of action, novel therapeutics for patients in bladder cancer. We've seen incredible advances in the last 6 years. I mean, we talk about living in dog years, where 1 year is 7 years. The last 6 years have been unbelievable. You look at a drug such as Pembrolizumab, which I think has over 30 approved indications for different tumor streams in the last 6 years, just for that particular checkpoint inhibitor. And I'm sure if you look at the checkpoint inhibitors, avelumab, durvalumab, atezolizumab, and nivolumab, now you have 5 checkpoint inhibitors that are approved in the area of bladder cancer. We also have many of these involved in kidney cancer, many of these, or more opportunity even in prostate cancer. We'll talk about that. But what's really exciting to me in the last 6 years is recognizing that Urooncology is part of the multidisciplinary team here. I think it's great that the AUA has courses like this. This gives us all an ability to say, how do we broaden the field? How do we broaden exposure for, most importantly, so patients can get access? I think Gordon and Tom and myself were fully aware that 80 to 85% of cancer care happens in the community. We have tremendous cancer care that happens at our tertiary and academic centers, but that's only 15 to 20% of it. So how do we make sure that we get patients who have bladder cancer get access to all of the level 1 evidence, grade A evidence, and get the right care that they need with the right physician and at the right time? And that's our goal. There's no longer internecine concerns of subspecialty or specialty versus another. That's a really tired conversation. The real thing is patients require the ability to have access to care. And they require access to care with someone, ideally, in this forum, we're talking about uro-oncologists who can deliver that care, not just in the United States, but globally. So I really, again, thank Tom J. Ram for putting this all together. We're really glad that we have so many people watching virtually, and for the folks here in the audience. So here's the first question. Which cancers that urologists treat have a specific FDA approval for immune checkpoint inhibitor therapy? Is it renal cell carcinoma, urothelial carcinoma, prostate cancer, penile cancer? Is it 1 and 2 or 1, 2, and 3?
So, text 22333. Go to the next slide. Yeah.
Oh, okay.
Figure this out together.
Whoa.
Okay, so you can see the instructions at the top. Text AUA meeting 818 to 22333, and then text your answer. Let's give them a couple minutes really for that to happen.
Yeah, while you're filling this out and getting on, you can read the question and consider the answers. We'll give you some time here. We don't have any musical interlude, although Dr. Brown is known to break out in a cappella songs if he gets the right request.
It's kind of a trick question, I will say myself. It's kind of a trick question. All right, well.
Are we going to see the answer pop up?
I don't think we're supposed to.
Oh, this is the pre that we did the post. Right. Okay, thank you. All right, we'll get to question 1 at the end of the answers. Have you considered infusing your own immune checkpoint inhibitors within your practice? Yes, I'm already doing it. Clearly, Doctors J. Ram, Brown, and Shore are. Yes, I plan to start. No, we may consider down the road. No, not at all.
this one I think we can see the answer to.
Okay, so we have a split. We have half saying, yes, I plan to start, and half saying, no, we may consider. So I think what we're hoping at the end of this course that the 50% who are the Bs are going to stay loyal to that after our presentation, and then the 50% who are considering are going to be, the Cs are going to become Bs. And I'm glad we don't have any Ds there, but in the future, maybe we'll get some more Ds here and then convert them to Bs. I think we're ready. Okay, so I've already gave you a little bit of a preamble about, why we think immune checkpoint inhibition or uro-oncologic opportunities, PD blockers, a lot of different ways of spinning this, saying it. Verbiage counts, but at the end of the day, who are the initiators of immuno-oncology in bladder cancer? And the answer is urologists, because we've been giving BCG since the 1980s, thanks to Pablo Morales. And so we understand that immuno-oncologic benefit exists. In prostate cancer, urologists have been, at least in the community, really at the forefront of giving Sipuleucel-T, which is an immunotherapeutic in prostate cancer. And so now we have this incredibly rich opportunity, rich when I say that in education and in patient benefit, for immunotherapy in GU oncology. It's not just in bladder anymore, but there's opportunities in kidney and prostate. Largely, though, right now in bladder, but certainly in kidney as well. And our presentation today is to just kind of talk about the broad brushstrokes and why this is so important without getting, very deep into a data dive on all these amazing trials that have been out there, because there really are some. But we're going to talk about the background today. That's my charge, and then Gordon's going to talk about the implementation. And then Tom's going to review, which we think is one of the biggest barriers to entry, is just how can I deal with this from a safety and an adverse event and toxicity standpoint. So we want our listeners to say, yeah, I can do this, A, for the right reasons, because there's clinical utility and relevance. B, I know how to implement this. It's not that cumbersome. We have some really great videos we're going to show you of our nursing key members who and how we do it. Unscripted, live. Well, that's not live. It was live when we recorded it. But, and then ultimately, how do we think about safety and adverse event management? And Tom's going to review that. We have had, over the course of time, a limitation on existing therapies. Let's talk about first, non-muscle invasive bladder cancer. I remember back in 2016 when I had the really good fortune to do a program with Judd Mal and here at the AUA. I forget where it was in 2016, but it was the first CME symposium that had been done on advanced bladder cancer in literally like 25 years. That was 6 years ago. And it was me and Dan Petrolak and Judd Mal, and I think Rob Dreiser was on the panel. And the place was packed, and people were like, wow, this is cool. It was a CME dinner symposium, and we were talking about the new potential, the new FDA-approved indications for atezolizumab at the time in frontline metastatic bladder cancer. But prior to that, let's look at BCG and its role in non-muscle invasive bladder cancer and the evolution with intravesical chemotherapies. The recent approval of Pembrolizumab in BCG unresponsive CIS, a really big deal in 2020 that came out. And there is a clinical trial pipeline that is so amazingly robust right now, maybe we'll talk about that later, in both intravenous and subcutaneous administration of checkpoint inhibitors in both BCG unresponsive disease for high-risk NMIBC as well as for BCG naive. This is all part of the uro-oncologist domain. I mean, bladder cancer, whether it's TAG1 or G3, but but certainly TAG3 and CIS and T1, particularly the high-risk NMIBC group, is super important in trying to optimize care. And if you put that in conjunction with the BCG shortage, which different parts of the country, different colleagues around the world have shortage. Not everybody does, some do. And I think to the credit of the manufacturers of BCG, they're doing their best to up the production. We have tyrosine kinase inhibitors that have been utilized particularly in renal cell cancers for the longest time. There's probably now 7 to 8 different oral tyrosine kinase inhibitors that are available with or without the addition of a checkpoint inhibitor. Very, very important for our colleagues to understand how these oral therapies work, but that's a different conversation. They're technically not immunotherapies. We have antibody drug conjugates that have been approved, other oral agents looking at FGFR inhibition, all in bladder cancer, as well as applications in kidney cancer. So it's not about, to me, if you're going to be doing this, it's when are you going to start. Tom and Gordon and I have been involved in the education of advanced prostate cancer clinics, or what some call APCs. You could pick your acronym of choice. But then there's also the ABC, the Advanced Bladder Cancer Clinic, and the Advanced Kidney Cancer Clinic, or what some would just say you should have an ACC, an Advanced Cancer Clinic, with all due respect to the Atlantic Coast Conference in the Southeast. That's a U.S. thing. So there is just a flurry of on-label and off-label. We're going to stick to on-label stuff. This is a CME presentation. But the awareness, boy, in 6 years, there's been quite a bit and more coming. There were new data presented here at AUA in 2022. There's going to be exciting new data presented at ASCO 2022, and there will be more data next year at AUA 2023 in Chicago. Data that's going to come forward at EAU and at ESMO. This is a remarkably exciting, vigorous, enthusiastic time to be a uro-oncologist. I mean, it's a great time. There's so much involvement, so much more we can do for patients, and so much more we can do in the clinical trial landscape. So I think what I'm trying to get across here is how passionate Tom and Gordon and I are about helping our colleagues organize and delivering advanced therapeutics, not only in prostate cancer, but now in bladder cancer and kidney cancer. And this is sort of the overarching theme for today's program. Gordon's going to spend a bunch of time really kind of, and we're all going to be talking back and forth on, the workflow and efficiency. So many times, our industry colleagues, even our association colleagues, whether it's AUA or LUGPA or EAU or SUO, will say, well, what's the workflow? How do you do, what does good look like? And the answer is, it looks like a lot of different things. There's a lot of heterogeneity and local ways of doing it and doing it well. And it's not a one-size-fits-all. It's what works best in Nashville, Tennessee versus New Jersey versus South Carolina, or in even for my role working with colleagues in Genesis Care, and those are in a bunch of different states. I think it's really important we talk about the patient experience. That is the North Star, right? Is how do patients get optimal care to all of the approved therapies? Cure is ideal, but if they're not going to be cured, and let's face it, patients with advanced bladder cancer, first line or second line, post-RC or metastatic at presentation, clock is ticking fast for them. This is a much more aggressive disease as a general rule than for our patients with advanced prostate cancer. So familiarity and experience, and getting the experience and getting started up is absolutely a quintessential goal for not only U.S. uro-oncology, but uro-oncology globally. So that's why we're here to talk about how do we enhance access, how do we enhance this awareness. We'll talk about clinical trials if we have some time, multimodal options. Is it just an IO therapy, a checkpoint inhibitor? Can you combine it with other things? Will it ever be neoadjuvant? Is it only adjuvant from our patients with muscle invasive disease and or metastatic? A lot of different options out there now. Combinations, neoadjuvant, adjuvant, really exciting time. The adverse event management, Tom's going to talk about this. It's one of these canards that I've heard over the years. Oh my gosh, if Tom's not available or Gordon or Neil aren't available, what's that on-call physician going to do? I find that so startling that people still ask that. Non-oncologic urologists are pretty smart folks, and they can handle a call from somebody saying, hey, I have a fever, I have a rash, I'm dizzy. Things can be handled for the on-call physician. That should not be a litmus test for being able to do these therapies. Most importantly, it's education. Typically, in my experience, I'm curious what Tom and Gordon think, is your allied health team, whether it's your nurse practitioner, physician assistant, MA, RN, really carefully educating patients about what to expect. Not dissimilar for how we treat all advanced GU oncologic therapies, but very true about IO therapy, and Tom's going to go over that. Centralizing care, efficiently organizing this, having nurse navigators. We hear a lot about this. It's very important. We have a physician shortage of people. We have a graying of the world, which means an expanding geriatric population. And bladder cancer, kidney cancer, prostate cancer, this is a disease of the geriatric population, by and large, not exclusively. And with this expansion, more and more patients with advanced GU oncologic concerns will need a uro-oncologist to be central to that activity and that care and that diagnosis, that evaluation and that management. We're working really hard to bridge these gaps in the community. That's courses like this and the importance of how do we create pathways. They can't be too simplistic, but a pathway that nonetheless gives you a roadmap to say, okay, how am I going to use my IO therapy in bladder, kidney, prostate cancer, whether it's on approved indication from the product information to clinical trials. And all three of us do a lot of clinical trials, and we're always encouraging our colleagues to stand up and get their clinical research bona fides, because that's really the ultimate goal of being a physician scientist. So we have immuno-oncologic approvals in bladder cancer. Pembrolizumab, as I mentioned earlier, this is a very important approval that occurred in actually I believe it was in February of 2021, if I'm not mistaken. But thanks to pioneering work by Arjun Balar and others, and many of us who participated, I know I was part of this trial, the Keynote 57. I know Tom and Gordon, I believe you guys were very involved. And so this is really the first and only to date indication for a checkpoint inhibitor in patients who have BCG unresponsive CIS. Heretofore, we give rounds of BCG, we give rounds of intravesical chemotherapies, whether it's mitomycin historically or now most recently gemcitabine and or with docetaxel. But at the end of the day, there's a proportion of the BCG unresponsive CIS population which will ultimately go to cystectomy. I think it's fair to say that most patients, the overwhelming majority of patients, would like to try a therapy. Did I lose the, you still hear me out there? That would like to try anything to maintain their bladder. Nivolumab as well as others, and this is a very, very important study published in New England Journal, Dean Bajoran, the Checkmate 274. I'm not going to go into the details and show you the study schema for this, but for adjuvant treatment of patients post-radical cystectomy with high risk of recurrence, and you see the breakdown here of chemo-naive, prior chemo, and these are typically platinum-based therapies, and regardless of their immunohistochemistry PD status, there was a 2-time median disease-free survival benefit in patients receiving nivolumab. This is really important because we now have entered into the arena for maintenance therapy, frontline therapy, post-platinum progressive therapy for patients to receive immuno-oncologic therapy. So maybe a lot of the urologists who are listening are saying, well, wait a minute, I walk away after a patient I walk away meaning I'm not going to be part of the treatment management if a patient's going to get platinum-based therapy, which I fully understand. But two caveats to that. One, not everybody is platinum eligible. And it's very important for our colleagues out there to understand what are the criteria for platinum ineligibility. They're oftentimes called the Galsky criteria. And to be ineligible for cisplatinum, and all of the data really speaks to receiving cisplatinum, whether it's in MVAC or dose-dense MVAC, and not really getting carboplatin. And there's a difference in those molecules and their efficacy. But to be ineligible for platinum, there are criteria that have to do with having a baseline adequate creatinine clearance, having avoidance or lack of hearing toxicity or neurologic toxicities, and other cardiovascular issues as well. So not everybody's going to get platinum-based therapy. That said, it's level 1 evidence that in the neoadjuvant setting or in the patients who didn't receive it in the neoadjuvant setting, who had RC or who present with first-line metastatic disease and they're platinum eligible, they should receive that. If they don't, then there's a multitude of checkpoint inhibitors, PD blockers, and we've mentioned them already, where patients can benefit with bladder cancer. Now, as it comes to, that's just bladder. Let's talk about renal a little bit. Great work by Tony Choueiri. Tony Choueiri has really been one of the absolute leads in renal cancer systemic therapies. Brian Rinne in the United States, Tom Powles in the UK. Great friends and colleagues to the urologic community. But pembrolizumab in this particular trial also published in NEJM, the Keynote 564, and this supports the results to use pembro as adjuvant therapy for patients who've undergone a nephrectomy who have high risk of recurrence. Important to understand the stratification for what's considered low versus intermediate and high risk. There are different algorithms to look at. They're not complicated. You just plug them in. But if you have high-risk issues, then you're a really strong candidate based upon the study. As you can see in the Kaplan-Meier, a separation of the curves for disease-free survival benefit at 2 years between those who receive pembrolizumab versus those who receive placebo. So another indication of another different IO. And there's other great studies in a multitude of the 5 different checkpoint inhibitors. We're not trying to pick one versus another. We feel that you should be familiar with these, and that's a much more in-depth presentation. We really want uro-oncologists to recognize that you have opportunity to use it in a multitude of different settings in GU oncology. So I talked about bladder, I talked about kidney. What about prostate? Well, genomic profiling is so important now for our colleagues around the world in so many tumor streams. I was focused on prostate, where I think most of us are hearing the importance of testing for germline or hereditary risk cancer as well as somatic for patients who have, or another way of thinking about somatic is the tumor tissue, making sure there's adequate tumor DNA, and that can be obtained either through tissue specimens, prostate biopsy, archival or fresh, or it can be obtained through the prostatectomy specimen, or it can be obtained through metastasis-directed biopsies, or it can be obtained, if you can't get the tissue, blood-based, or what we call liquid, looking at circulating tumor DNA. If you happen to have what's described as microsatellite instability, which you can find on a variety of different testing platforms, then you have a tumor-agnostic indication for Pembrolizumab. There's also, and it can be a little bit controversial, looking at the notion around tumor mutational burden, particularly if you have more than 10 mutations per megabase, words that you may not be completely familiar with, but it opens up an opportunity to have the use of a checkpoint inhibitor such as Pembrolizumab. And even though the last bullet talks about only 4 to 5% of patients, if you do enough testing, you'll find these patients. And it's a really kind of a nice eureka moment where you say, hey, guess what? I have something for you that it adds to the armamentarium of the toolbox. We see things like this in other gene alterations in metastatic colorectal cancer and other tumor streams. And so the whole field of advanced oncologic potential is not just in geo-oncology, but it's throughout numerous tumor streams: breast, ovarian, pancreatic, lung, colorectal, and more. So what are the future applications of immuno-oncology and urology? Well, we always like to think, sort of your first shot may be your best shot. Patients have a better performance status. They tend to be younger. Maybe they have less tumor burden. Typically they do. They may have a more enthusiastic approach towards multimodality therapy. And again, their performance status is usually better and they're more motivated. So we're looking at, and assuredly we will have successes in the neoadjuvant and the perioperative application in renal cell cancer and in urothelial cancer as well, especially for the patients who are platinum ineligible, and also for patients that's cisplatinum as opposed to carcinoma in situ. And there's an exciting opportunity to even combine checkpoint inhibitors with BCG and other intravesical opportunities. So I think we'll go, this is Joni Fall, who has been my director of systemic therapies in my clinic, not in my research component. And she is just, Tom said, let's just do a video completely off the cuff. And so here she is. I don't know, do I activate this or do our AV expert activate this? Looks like you do.
Hi, everyone. I'm here with my nursing director of all of my systemic therapies, Joni Fall, and this is Neil Shore on the camera. Joni's been with me for 6 years, and thanks to her, we've been able to administer checkpoint inhibitors to our patients with bladder cancer and for approved labeled indications. Most recently, for BCG unresponsive CIS, we also administer checkpoint inhibitors for patients in first line and second line metastatic urothelial cancers. So Joni, maybe you can share with our colleagues your experience.
Hello, glad to be here with you today. And what I have here is our infusion room. So whenever Dr. Shore identifies the patients who qualify for our immunotherapies, we start with education, and then with the patient, I bring them in, have them sit in our recliner chair. I talk to them about the medication they're receiving, any type of immunotherapy responses that they might have adverse reactions to, and to kind of let them talk to me about what they're feeling and what they think about their treatment. So after we get through with the information, I have them sign a consent, and then we establish a date and time for them to start. We also make sure they have the pre-labs done. We're looking at their anything that could correspond with their amylase being elevated, or if their thyroid's not working correctly.
Or Dr. Shore's iPhone's not working correctly. Do we lose Wi-Fi there?
I think that was it. It was only a minute and a half. So.
Oh, is that it?
Yeah.
Apologies for the camera work. But what, I think the thing that you want to see in that is, one of the things, and maybe we'll have an opportunity to talk a little bit here. When I first started doing infusions and zoledronic acid and CYP and other things, people would say to me, well, what's your infusion suite look like? Do you have a suite? I'm like, I don't have a suite. I have a Barker lounge. It's a Barker lounge chair. I know I'm not promoting Barker lounge chair. It could be any lounge chair. You can get it at, Costco. An IV pole and a comfortable room. You see, we have the beach motif. I'm at the beach. So, and a really dedicated nurse. The key is really the most important aspect of this room is the nurse who does all the pre-education and is really in that room for a period of time during, before, during, and afterwards to really talk to these patients and let them know about why they're getting the care that they're getting, why they're getting the treatment, how the treatment works in layperson's terms, and most importantly, what to expect afterwards and what's the follow-up going to be. But let me stop with that. What do you guys?
Yeah, so we'll touch on this a little bit as we go through the balance of the talk, but I think it's an excellent point. And our infusion suite is a little bit different based on our geographic locations of the suite because we're over a large geographic area. But I think what's important to kind of highlight is that the experience wherever they are is exactly the same experience, and the infrastructure as it relates to dedication of the staff is kind of easily reproducible, whether that therapy is given in the greater Philadelphia area, whether it's given in the greater New York area. Some of our suites are very similar to Neil's, where it's simply a recliner and an IV pole, and some are more sophisticated and more centralized with a couple of chairs. But I think the thread that pulls through is the clinical excellence piece, the staff that supports that patient journey, and having an environment in which they feel comfortable receiving these infusions, irrespective of the overall kind of size of the infusion suite itself.
Yeah, I think I would just add, I think one thing that all three of us agree with quite strongly on is the overarching concept that you don't need a massive amount of infrastructure or new infrastructure to implement these programs. I think if you have a practice that has infusion capabilities, if you've had advanced prostate cancer programs, utilize your strengths, utilize what you have. That's a very common question is well, how many new people do I need to hire? What do we need to do? Do we need to break walls down? And the simple answer is no. None of us have done that. We've all utilized what we've had. And I think that's a pretty common theme of this talk is that.
Yeah, I would also add that, from an FTE perspective, it can be somewhat FTE light, right? I mean, we can repurpose existing, not to make them sound like driftwood or something, but you can kind of reassign roles within the practice to existing advanced practice providers to help support programmatic development, especially getting going. And then as you become more robust over time, you may find the need to add additional FTEs.
Okay. Go to the next slide. Okay, so here we go.
That's Gordon.
I think this is you.
All right. Thanks, Neil. Excellent, as always. So I'm going to spend the next 25 minutes or so talking about how to operationalize this therapy within our practices. I promise you I won't break into a cappella unless it's Broadway in nature. But we're going to start off with another kind of ARS question here. So for the group, what seems to be the biggest barrier to administering checkpoint inhibitors in our current practices? One, we're unfamiliar with the drugs and their indications or utilization. Two, we have logistical concerns around the infusions, how to administer them, space required, etc. Thirdly, side effect management concerns, whether that's us individually as providers, or that's to the practice as a whole. And then economic concerns. Are there economic concerns around reimbursement practices, revenue cycle management issues, cash flow issues within the practice, on-label approvals, et cetera? Or lastly, none of the above. All right. The last ARS question here is going to be an understanding of USP 800 will allow our practices to, one, provide cheaper acquisition costs from distributors of the existing therapeutics. Two, ensure a safe environment to help protect their staff against hazardous drugs. Three, better manage side effects of checkpoint inhibitors. And lastly, bill for the drug more successfully. Were we able to see the responses to the first question? For some reason, it didn't come up. Is there a way we can go back to that? Yeah, usually there's a response. Here you go. Okay, thanks. So this is, I think, an important concept, and one that Tom will I think, certainly highlight in the context of this talk. Side effect management, either from an individual doctor perspective, getting up and running, or if it's not for the urologic oncologist or disease matter subject expert within the practice, maybe to the partners on call. We'll talk about how to manage that and how pathways can help mitigate some of that concern. I think that's certainly something which will be, as we use these more effectively, you'll find that there's, I think, fairly straightforward ways to identify these patients, and as Neil alluded to, ways that we can very effectively manage these side effects within our wheelhouse on a very consistent basis. And we should feel comfortable doing so as kind of thoughtful, engaged, just generally practicing urologists without any necessarily additional training required. All right, so Dr. Shore did an excellent job, as always, really kind of highlighting and underlining the clinical benefits to the use of immunotherapies within our clinical practices to improve outcomes in patients with various urologic conditions, whether it be bladder, prostate, or renal. And really the goal in the next several slides is to try to understand how we're going to how we're going to operationalize these programs and bring them in-house to our existing urology practices to allow our patients in the real world to gain benefit from the utilization of an immuno-oncology clinic. And so we've identified kind of four pillars or four essential elements of a really robust and effective immunotherapy clinic. We're going to go through these in much more detail in subsequent slides, but it really starts with kind of a discussion around shared buy-in. And there are two major stakeholders in this initially to drive programmatic change, one being a physician champion, somebody who really wants to continue to deliver integrated care along the disease continuum for a specific disease state, and who wants to kind of start immunoinfusions within the practice. Secondly is going to be the administrative champion, somebody who administratively, usually on a CMO or a CEO level, is able to help us kind of further operationalize this from a financial perspective, as well as from an infrastructure investment perspective, to make sure that we're doing this effectively and thoughtfully and successfully. And it's these two kind of initial champions which are going to drive subsequent process change within practices. And as you can see, we're going to talk about the provider. What's required from a provider perspective? Is this, and there's providers is a very broad term. It includes physicians, it includes mid-levels, it includes nurse navigation, in my opinion. And in my opinion, it also includes the insurance benefits verification people, the folks that actually allow our patients to get access to these therapies. We're going to talk a little bit in depth about the patient identification, some of the challenges associated with that, and some of the barriers that we may see from internal referrals within our clinics. We're going to talk about the benefits of pathway-driven care, the efficiencies inherent within pathways, and how to develop pathways for specific disease states, and try to get reproducible care, whether that care is given in the greater Philadelphia or the greater New York area. And talk about really, the minimal infrastructure and physical plant requirements which are going to underlie the development of successful IO therapy clinics. The slides really kind of highlight, I think, the underlying tenets of providers, including champions, physicians, navigators, data analysts, all driven by pathway-driven care and highlighted by data analytics along the way to kind of pressure test to make sure that we're actually doing the things that we think we're doing, providing the appropriate care and the appropriate patient along the way. All right, so what are some of the barriers, to get this up and running? Well, as we alluded to earlier, we're going to have kind of two drivers of change within individual practices. That one, first driver of change is going to be that champion physician, the other one being an administrative champion. These two individuals are going to have to drive cultural and infrastructural change along the practice itself. And I think this is probably one of the most important kind of stumbling points for any individual practice getting up and running to, whether it be an APC, an ABC, or an ACC, as Neil described, to having these programs be successful is really the required change in the practice culture. So I think it has to start with a discussion around the clinical excellence piece and around the data that Dr. Shore presented, and educate our partners around that need, around the changes in practice and the clinical benefits to delivering these therapies within practices. And then it's going to be followed up with a discussion around transitioning these patients from patients of individual doctors to patients of the practice. So we're going to be taking these patients away from a patient of Gordon's or Neil's or Tom's to now being a patient of our practice. And that's not to say that these patients aren't going to have a relationship with their referring or existing urologist, but it's to say that to make this successful, we can't have the referring urologist undermine the process of internal referral. I think that cultural change is going to be a very important one, and one that's essential to successful programs that we're referring to.
Let me just ask you guys, because I think this is a big piece here. Neil, what's been your experience with that kind of model of group referral? We've talked about an AP, and I think all of us have some double vision on this because we've seen it in APCs pan out too. If you build it, they will come. Is that applicable? Do you find that your colleagues and your partners, once they've seen that there is a disease state expert or an expert that has a certain expertise, can attract patients, easily from other colleagues?
Yeah, it's a great question. I wish I could say the answer is an unequivocal yes. Unfortunately, it's not, because there are a lot of factors that go into play. As it relates to the physician referral, it's complex. There are those physicians within your own group who will say, I don't want to take care of these patients because I'm focusing on complicated stone disease or complicated LUTS or complicated ED or infertility or pediatric urology. And they're very happy to refer to someone like yourself or Gordon, Tom, and they're thrilled that they have it in-house and that they have expertise, and they don't want to have leakage to outside the institution. Double entendre, we can use the word leakage as urologists. It's always fun to throw that in. But then unfortunately, and here's sort of the challenging part, we have colleagues who may recognize that they can't keep up. They don't know, they don't have the knowledge, and they don't send it internally to one of us because maybe there's a disincentivization economically. Maybe there's an issue regarding ego and autonomy and politics. And I think that's one of the things that we have struggled with, but we're doing so much better with it. And that's really where it's about leadership, it's about culture, it's about education, and it's about listening to why there would be some hesitancy to internally refer. I think once you can establish that you have someone in your organization who is truly committed, who is following the literature, and the whole issue around economic incentivization, disincentivization can be very complex. Sometimes there are geographical barriers, less so if you're in a smaller organization. I mean, Gordon, his group's throughout the entire state of New Jersey. And so there can be geographical barriers to entry, and so putting the satellites in that can do things well. And it's an ongoing work in progress, Tom. And we continue to try and do the best we can. And it's not to say we can't incorporate surrounding medical oncologists, both within the community and academia. My goal, as I said in the beginning, is to have it all in-house and to do it as well as we can. But these are some of the things that we struggle with. For our overseas colleagues who are listening, I realize there's a lot of different reimbursement methodologies for the physician, the healthcare provider, and also for the payers. So we're all in this together. Again, it's all about convenience and excellence of care for the patient, and hopefully that will ultimately win the day.
Yeah, I would add that, I think ego and financial disincentivation to internal referrals are two big issues that we struggle with. Certainly, I think bringing this discussion directly to the partners prospectively as opposed to kind of hoping things will change over time is probably the most direct way to address this prospectively. And then once you have group buy-in, at least our experience has been that this goes from more of a forced model where you're kind of prospectively identifying patients and bringing them into centers of excellence to very much of a passive model, as Neil described, where you're having people identify appropriate patients and sending them in very early on in their disease course, which is really both to the practices as well as the patient's benefit. I would further add that once you do have a successful culture, and something that we've had some growing experience with, is that as you grow and evolve over time, it's really important to translate that cultural success locally to global sites, right? So across large geographic areas that might be disparate or over a larger number of providers, such that you don't lose some of the initial traction that you've gained and some of the programmatic benefits that are going to be translated to your patients. So I think that maintaining a successful culture as that practice grows and evolves, as we all are, pretty consistently now in urology, I think is a very important underlying, concern as well.
Yeah, great. And I would just add that I think things are getting better in this respect. I think trainees are coming out a little bit more, like Neil said, that they want to be disease experts, and they realize that you can't do everything really well. Certainly in the community, all of us wear a few different hats, and we're all to a certain degree general urologists, despite our advanced training. But I think with the younger generation and the younger kind of breed of trainees, I think that this is getting better. And in our group, which is a slanted a little bit younger, I think one of the strengths of our group is having this kind of culture where people are very happy to send things in. And like Gordon said, there are some components about incentivization and how things work at the end of the day, but it's fundamentally a practice culture thing that needs to be identified to make this work, because one or two providers cannot make this program, run by themselves.
Can I just piggyback to that? I made this point the other day during the IBCG. It was during the IPF, and the concept was and just want to echo what Tom just said. I don't want to be generationally biased, but I guess I will be. And I'll say that the younger generation, you can define how younger is. It's anybody who's not a baby boomer, are much more, as a general rule, collaborative. They're more collaborative. They're more emphasis on the team. The baby boomer population are the ones who went to pre-med, med school, where they got the sort of the mantra, look to the left, look to the right, one of you is never going to get into medical school. And then you go to residency, it's like, look to the left, look to the right, you're not going to get a fellowship. So, there was really a lot, it was very, very competitive and very, not an emphasis on collaboration. And so I completely agree with what Tom was saying, is the younger generations are infinitely more collaborative. They understand the importance of really patient first as opposed to provider person, physician first. And I'm very optimistic about that. Now, semicolon, what I brought up at the IPF yesterday in the advanced prostate cancer milieu, and I think the same is true in advanced bladder and kidney cancer, and this concerns me, is there's a tremendous growth in the urologic community, and not just in the US. Our colleagues in Italy are very aggressive about this, and in Germany and Japan, which I think is great, is uro-oncologists understanding systemic therapy. But if you look at the educational programs in the US, I won't speak for non-US, the urology residents and fellows are not getting training in advanced systemic therapies. And so that is very concerning to me. And the irony is, when they go to take their boards, they're asked all these questions about IO therapy, and they're asked all these questions about systemic therapy and geo-oncology. And they're getting the training when they come to the community. If they stay in academia, there's real, red lines where the urologists are still following, I think, apologies for any of my colleagues in academia who are doing a better job of this than what I'm portraying, but it's still largely a surgical oncologic field in academia. We have colleagues who understand the literature and are part of papers, and they become trial sites, but it's the medical oncologist who are actually doing that touch point. And I think it's great that the AUA and Tom doing this course for us. This is what we need to continue to do, because it gets back to, you can't just know about something, you got to be able to be directly involved with it. So that's kind of an odd irony that's happening right now in training, and then for those who come out into the community.
All right, so another potential barrier being the USP 800. For those who may not be familiar, this is a set really of rules and regulations which is outlined by the federal government and administered by the National Institutes on Occupational Safety and Health, which really gives us an understanding as to how to receive, store, handle, reconstitute, administer, and dispose of hazardous drugs. And within that, there are three kind of classes of hazardous drugs. The first class including anti-neoplastic therapies. My current understanding, is that immunotherapy is not, included in the USP 800 indications currently, and that this is really meant to, protect, those people who are kind of handling, storing, and administering it from safety concerns around the patient care model where they're going to be delivering these therapies, and to make sure they're doing it safely. You also have to kind of understand some of the challenges which can be existent with site-specific reimbursement issues and revenue cycle management. Nothing will undermine the development of a successful IO clinic more than doing it at a loss, or kind of running at a revenue-neutral kind of proposition based on infrastructure and perceived, at least, clinical risk. So it's important that our administrative champion help us navigate those waters. It's important that they understand the local payer mix. A lot of these therapies are buy and bill therapies, so we have to understand the expected turnaround to reimbursement after administration, and what that percent above purchase price might be to help us make sure this is going to be a financially viable endeavor. Certainly, that can't be done in a vacuum, and we have to understand there may be different reimbursement based on whether these therapies are given in the hospital setting, the clinic setting, or as an at-home infusion. And really, the goal here is not to undermine the relationships with our medical oncology colleagues, but rather to foster them, right? And that the patient is at the center of this care model. The goal here is really to practice multidisciplinary care and deliver these therapies safely and efficiently within our existing practices with on-label indications and in clinical trials when appropriate. These patients certainly may require medical oncology intervention at some point during their care model, so we're not looking to undermine, long-standing either, personal or professional relationships with our medical oncology colleagues, but rather foster them really for the benefit of our patients. So,
Well, Gordon, before you finish, I do want to hear, the models are different across the country and really across this table in terms of how these are delivered. Neil's practice and my practice, we deliver these ourselves, with the kind of the champion urologist model. And in Gordon's practice, they have an in-house medical oncologist. So to do this, and that's becoming a very popular model, to bring in a GU medical oncologist either on a part-time or a full-time basis to both administer these therapies and help with clinical trial support. So I do want to touch on that before you switch out, about what your thoughts are on that model and how that's been viable.
Yes, I appreciate you kind of highlighting that. From our perspective, we actually started with the urologist infusing this, and the volumes became such, and the geographic diversity became such, that we had to really bring in additional providers. And we felt that at least in the region where they were, they felt more comfortable really hiring a medical oncologist to administer that therapy. So we went and hired a full-time medical oncologist to oversee and run kind of the northern portion of our practice, which is about 80 miles north of where I am currently. And so he, in that context, has an infusion suite, which is much nicer than mine, but nonetheless, and really oversees the care of these patients. It's a very collegial and collaborative, kind of endeavor, quite honestly. It's one that we have shared grand rounds, we have shared tumor boards, and it's something that the group up there felt more comfortable bringing somebody in-house for their kind of immediate needs. So that he probably services, I would say 60 to 70% of our practice from an IO perspective, chemotherapy and oral oncolytic for advanced RCC, prostate, and bladder, in appropriate indications. So because of that, he's obviously a very busy person, and will require other people kind of ultimately underneath him as we continue to grow and evolve. We continue to kind of do our own little thing down in the south, in the greater Philadelphia area, where I'm kind of maintaining a practice with infusions. But that may be changing, frankly, too, because now I'm kind of servicing 30 plus urologists referring into us, and frankly, I'm not giving systemic chemotherapy, and we see the need to kind of expand that infusion line. So we're looking to hire our own full-time medical oncologist down there to kind of bolster that referral base.
Yeah, and I think the point is local service lines, local politics are different, right? Each of us have different geographical setups. We have a very intimate relationship in our setting with a big medical oncology group that we collaborate with quite strongly, and so one size doesn't fit all here. But certainly, whether you do it, you decide to bring it in-house or you decide to bring someone else in, it's getting to the point, as Neil said, where there's so much going on that really everybody who's a stakeholder in GU cancer care in your group should really be aware of what's going on and what the pop-off levers are to get these patients to the right person, to get them treated and evaluated.
Yeah, I think that's maybe the most important point, Tom, is that we don't want to not treat these patients, right? So or undertreat them based on the lack of either willingness to do it ourselves or in-house support to do it. We want to kind of refer them when appropriate to support and certainly not undertreat. All right, so let's talk a little bit about providers, and this is kind of a broad topic, but really is inclusive of a variety of different employees within the practice, including both physicians, APNs, infusion nurses, nurse navigators, et cetera. So as we've kind of alluded to along the way here, this champion physician, and my kind of general rule for champion doctors is that's about one doctor for every kind of 10 partnered urologists. I think it's, generally speaking, is a nice mix. This is, generally speaking, somebody who may be urologic oncology fellowship trained, but certainly by no means needs to be. They can just be a high volume surgeon who has a specific disease state expert interest and has developed their practice throughout the course of their practice life to kind of focus on specific disease states, whether it be bladder, prostate, or renal. And that they want to now expand their practice base to give integrated care from an infusion IO perspective within their existing urology practice. And this is obviously these patients, or pardon me, obviously these physicians have kind of usually ample internal referral sources built into their already day-to-day practice surgically, but now they're looking to kind of expand that footprint and deliver IOs. Now, with this transition, there may be multiple champions required depending upon the size and geographic disparity of the practice. And I think, the biggest thing to being a champion physician is, I think, the desire and the drive to actually do it, okay? There's no kind of intellectual secret sauce, nothing that is, I think, insurmountable as it relates to the data and understanding it and the application and management of this patient population. But you have to have the need or the desire or the want to do it. And I think trying to tap into those people within your practice will allow the development of champions geographically to be a much easier process and benefit not only the patient but programmatic development to a much greater extent. And as these doctors become champions, their time is going to be utilized quite differently, right? They're going to require direct oversight of their mid-level providers. They're going to have to help navigate patients along pathways. They're going to have to review AEs, labs, scans, have real-time interaction with nurse navigation to identify appropriate internal referrals. And they're going to have much more complicated discussions with these patients, right? Now, these are going to be much more complicated, not only disease state discussions, they're going to have much more complicated therapeutic discussions around therapeutic choices, including ongoing clinical trials research within the practice. They're going to have a very robust AE discussion. And when appropriate, sometimes end-of-life discussions, which are really not that kind of prototypical 99213, 5 years out from radical prostate with a native PSA and he's dry with good erections. We're tapping them on the butt and getting them out the door. So we're going to have to provide for that time for these doctors to be happy doing this and to be successful doing it. And I think that is a very important point. And equally as important as the doctor and development of the doctor champion, frankly, maybe even more important in some cases, are going to be the development of a good chemo nurse and a strong mid-level provider to help further kind of support not only patient care, but oversee the AE management a lot of times and identify patients, to kind of get them from intake into a specific disease state and actually started on infusional therapies. In my practice, for example, when we identify somebody to get Pembro for BCG refractory NMIBC, we may see I may see that patient a third as much, for example, as my infusion nurse and as my mid-level does. And I'm seeing them maybe as initial intake, and I might not see them until week 9 or 12 when we're following up interval cystoscopy for surveillance, assuming they've had an uncomplicated course. However, they've seen them every 3 weeks with my infusion nurse as well as my APP. So I think that having, again, people who are motivated and committed to that process is an important concept, and have the personality to interact with these patients and support them along their journey is an important individual to find. Navigation is another piece here which has to be, I think, recognized. And as we alluded to earlier, these roles can be somewhat hybrid in nature, especially when you're starting out, right? These roles, when you look at FTE requirements from an infrastructure perspective, you can have APPs who function as data analysts or navigators, and you can have infusion nurses who do the same. So the ability, or the need, I should say, to hire a bunch of different new staff, I think is very limited to when getting these programs up and running effectively. And the navigation is an essential, it's the cornerstone to all successful patient identification. The navigation, and we'll talk about how we identify patients in a minute here, but these navigators are really the ones that are coming to us on a weekly basis. I meet with my team twice a week by phone, once a week in person. That in-person discussion really is one that's around identifying potential eligible patients for ongoing clinical trials, looking at potential patients to be navigated into our center, and a review of ongoing treatments, AEs, those types of things within our existing infusion patient population or advanced cancer patient population. And these navigators are critical, and their ability to kind of sift through the data that exists within our EMRs and do that effectively for us is a critical component to bringing these patients successfully into robust clinics. And then the last piece, which I mentioned earlier when I started, was the insurance and benefits verification folks. This is something which didn't make the slide, but nonetheless is a cornerstone also of having a successful program, in as much as if we can't very efficiently and effectively get patients started on treatment while getting them benefits verified, that's going to be a stumbling point, right? These patients, if they can't get access to these therapies for whatever reason, they're not going to pay out of pocket for them. So these folks are folks that are going to help us make sure that these patients get the appropriate therapy for the appropriate patient in a timely fashion. And they're as critical a part of the team as any of the rest of us are. Okay.
Can I just
let's
make one quick?
Yeah.
So great review here, Gordon. So awesome. So it's the three comments. One is the notion around clinical trials. I think this is just a gateway opportunity for sites that have volume, have scale, have passion. Once they start doing the approved therapies, they become great potential sites to do clinical research if they're not already doing it. We've gone in the last 6 years to having more trials now in Immuno-Oncology than we have sites. It's a real challenge for our colleagues in biopharma, because we need more quality sites. And if you become a really high-performing clinical site for approved treatment, then it's just such a simpler way to then segue into becoming a clinical research site, which is the ultimate physician-scientist goal to advance healthcare, period. So that's a great point that you put in there. The second thing, from a payer standpoint, is by offering optimal care, meaning to the right patient, right time, with the right team to avoid and manage toxicities, which Tom's going to talk about in a second. Why is that important? Well, number one, it's great for patients, but number two, you keep patients out of the emergency department and out of the inpatient hospital system. Those are the two biggest health economic outcome drains in all healthcare systems, not just in the US. So if you manage these patients really well with the right team that Gordon's just really gone into in a lot of granularity, keep people out of the ED, keep them out of the hospital. And then and what patient doesn't like that, especially during COVID? And then third, and I think this is a really important point, and I think it used to be kind of a third rail for urologists when we'd start to talk about palliative care or hospice care. I will tell you that some of the most amazing moments for me as a physician is in end-of-life care. And it is for my healthcare team, too. I never thought I'd be saying that as a urologic surgeon. And I think a lot of urologic surgeons are like, oh, I can't deal with that. A lot of medical oncologists have a really hard time with it, too. If you read JCO, Art of Oncology, there's some amazing editorials there. And to me, that's one of the most incredible experiences, and it's an enormous privilege for the entire healthcare team that you have to deal with people who are on the, the night side of life with a diagnosis of cancer. I think it's something that needs to be embraced. It can be an incredibly beautiful thing. And you learn to work well with your palliative care services, your hospice care services. It's an ongoing evolution, super, super important.
Yeah, I'll just chime in one thing. The finances are something that's frequently asked about. And we'd certainly have time to talk more about it, but I'll just chime in that, the primary revenue is fine. I think it keeps the lights on in the program. It supports the staff. It supports the program. But really, the piece is a bigger piece for a cancer center model. It's a bigger piece for a programmatic model, in that the revenue in the secondary lines, and we've all talked about this, and I think agree with this, is what can really drive the decision to do this. It's going to augment all aspects of your bladder cancer program. It's going to augment your prostate cancer program. It's going to augment your genetic profiling program to be able to offer this. And with that comes, I think, a lot of secondary, both visibility gains for the practice and the cancer center, and financial gains. So, the primary gain, these are fairly expensive drugs, and it's ASP +6, and so you'll get something back on this. But all of us know that there's also financial liability, right? In case some of those claims take a little bit of time to come back. So it's generally, I think, a stable financial proposition, or stable to good in terms of the fact that it supports the program. But really, to me, the bigger catch here is the secondary gains of having the program be enhanced and having all of your related service lines be enhanced.
All right, excellent discussion. So let's move on to patient ID, and we talked about this, I think a little bit, already, but we'll kind of highlight some of the salient points here as we go along. The patient ID, I think this is where we're going to see benefits paid off to our previous kind of changes around cultural modification within our practices and how we function. And having these patients really now be patients of the practice as a whole, as opposed to an individual physician's patient. This process can be as simplified or as complex as you choose to make it, quite honestly. This is really going to be the wheelhouse of our patient navigators and our data analysts, which are going to go into our existing EMR structures and look to identify an appropriate pool of patients who are at high risk of developing specific disease states. For example, those patients who have high-risk NMIBC, who may have received BCG therapy, who are looking for the BCG refractory patient to make them eligible for use of Pembro based on the Keynote-57 data. We can also have different groups of patients that we look at, and meaning that that intake could potentially be all high-risk NMIBC. It could be just patients receiving BCG, or it could be as finite as just those looking with a BCG refractory diagnosis. As a general rule, we try to cast a little bit of a wider net and then kind of narrow it down as we go along. There are, this can be done manually, or it can be more of an automated process. We started out, frankly, looking at CPT codes and, at the time, injection codes and previous therapy codes when we started doing this in prostate, a little over 10 years ago. And we've become a lot more sophisticated over time, but it can be done with just kind of hammering out some of the EMR data which currently exists. There are services out there which will provide for a fee, either direct nurse navigation or data analytics. There are also existing computer-based platforms which can go over your existing EMR. There are natural language learning platforms which will search for keywords within your entire patient base, and will grab your potential eligible candidates based on specific filters which you put in. These are not perfect, but they're much more efficient than going in and kind of trying to do these individually. I think specifically, as it relates to the bladder cancer patient population, the BCG shortage has actually helped us here. I mean, I'm not sure, what Neil and Tom think, but from my perspective, we keep a pretty concise BCG log now, much more so than we have historically, for two main reasons. One, we want to make sure that the people who actually let me take a step back. BCG utilization has been really all over the map historically. And so the BCG shortage really has had two intended consequences within our practice. One, it's really made the patients who truly always really needed BCG to actually get BCG, as opposed to those, as opposed to it being a little bit of a wider swath. Two, we've been able to more accurately and very effectively oversee the administration of BCG to make sure it's actually being delivered appropriately. And thirdly, it really has allowed us to have kind of a finite list of potential eligible patients for either clinical trial enrollment or use of Pembro based on the 057 data. Those are kind of unintended consequence of a therapeutic shortage, which has actually benefited, I think, programmatic development and makes patient identification a little bit more simplified, certainly in this context. I'm not sure if you have any comments about that, but so I think we can exploit sometimes some of these therapeutic shortages to benefit our patients, to get them onto to therapies which are going to improve their outcomes. And there is, as I mentioned earlier, a significant crossover between clinical trials research and patients in advanced stages of their disease or refractory to first and second line therapies who may be IO eligible. And that, we kind of constantly review this patient population for clinical trial enrollment and have a real commitment to development and support of clinical trials research whenever possible to help advance patient care. Pathways. So from a pathway perspective, this is the concept here, as everybody knows, is really to try to deliver reproducible, guideline-driven care efficiently throughout an individual organization, such that they're going to have the same care and same experience in the greater Philadelphia area in my practice as they would in the greater New York area. That's going to require a fair amount of coordination. And these pathways are going to be, kind of an overarching disease state pathway for those patients with high-risk NMIBC, but also gets as granular as, a pathway for these patients when they actually come in for their individual infusions, all right? So I know with a high degree of confidence that they're going to have the same experience. They're going to come in, they're going to have a patient identification. They'll have a bracelet put on, which much like a surgical center bracelet. They'll go back, they'll meet with my infusion nurse, they'll have their labs reviewed, they'll have their scans reviewed if appropriate, review AEs if appropriate, based on prior infusions. If appropriate, they'll get their infusion, they'll remain there and then have an assessment of any AEs and then be discharged. I know that for every patient that comes through, they're going to have that exact same experience. And the patients might not like me all that much, but they universally love my mid-levels and my infusion nurses. So they really are the kind of the mortar that holds this whole thing together for me and allows pull through from me identifying them to them progressing it, or not, hopefully. I think the pathways also allow us to have some confidence that we're not missing windows of therapeutic opportunity, right? That we're not missing a window to deliver FDA-approved therapies to patients that can benefit them, and it allows a standardization of care, which kind of ensures that from happening. It helps us identify and manage AEs and kind of oftentimes troubleshoot them. So I think from a pathway perspective, the pathways may be a little bit different based on the practice, but they're all going to be based on published guidelines and how that pathway is administered, how it's overseen, and how it's kind of pressure tested may evolve. So the pathway now may be a little bit different than the pathway in 6 months from now. I think that it has to be a kind of a living, breathing document, which is kind of reassessed as new data comes onto the scene. And then lastly, we're going to finish up. This is a picture of my infusion suite, much like Neil's. I don't have any beautiful pictures on the wall, but it's New Jersey, so I mean, there's not much beautiful in New Jersey, I guess. So we have an infusion suite. I think the concept and the general theme here is that the amount of infrastructure investment from a materials perspective is really minimal, all right? This is not a huge financial investment or overly sophisticated infusion facility. This can be done. I have a similar lounge chair with an infusion pole. It can be done within our existing plant and offices. This is an office, exam room in one of our offices, and it kind of like has a threefold, infusion for radiopharmaceuticals, infusions for immunotherapies, and infusion for a variety of other things on and off trial. So the USP 800 really isn't going to be applicable as it relates to IO therapies. However, if you do expand your program to include specifically systemic chemotherapies, you're going to have to make some additional infrastructure investment as it relates to hoods and specific storage facilities for reconstitution, administration, and disposal purposes to be compliant with USP 800. So I think with that, we're going to transition over to Tom, and we're going to have a discussion.
Can we hit play on this video? This is kind of take 2 on the video scene. This is my nurse. Oh, go back one.
Okay. Hi, I'm Lauren Ball. I'm the nurse practitioner here at Urology Associates, and I give all the infusions. So just want to discuss a little bit about what a day looks like here. So what happens is we go get the patient out of the waiting room. They come back into our infusion room. This is it. So pretty simple. You don't need too much. Just have the recliner there and the pump. So they will come back, and I'll just kind of touch base with them, see how they're doing, see how they're feeling since their last infusion, if there's any new side effects. We'll get their vitals, and then I'll start an IV, just a simple IV. Then I'll go mix their medication with some normal saline, and then come in and start their IV, which is given over 30 minutes. There's usually never any side effects or any infusion reactions. And then afterwards, I grab Dr. J. Ram, and he comes in and speaks with them about when their next labs will be or next scan, and then unhook them, and usually either they need labs every 2 to 3 months, so sometimes we'll get that, and then I'll set them up for their next telehealth visit, which is every 3 weeks, and their infusion is every 6 weeks.
Lauren, tell us about the mixing. Is that hard? Is it a big pain? Do you have to do it in a special room?
Yeah, so it's really simple. The Keytruda and the Opdivo both come and they're stored in the refrigerator. And then for the Opdivo, you have to mix it with 112 cc's of normal saline, and the Keytruda is with 200. So you just need to pull out so that you have those amounts, and then draw up the medicine in a syringe and mix it. So it takes about 5 minutes.
Okay. All right. So then after the patient's done, and we've kind of reviewed their course and their treatment plan, what's the follow-up for them? Yeah.
So. Then Kelly, our scheduler, will usually schedule them for a 3-week telehealth, which I do all of those. So I call them and just see how they're doing, touch base. Are they having any side effects? Do we need to call in any medications? And then she sets them up for their next infusion in 6 weeks for the Keytruda and 4 weeks for the Opdivo.
Great. And then at what point does the doctor kind of get involved in this process, or when does the doctor generate their visits?
So usually I'll go get the patient, get their vitals, go ahead and get their IV started and get their infusion running, and then I'll go and grab Dr. J. Ram, and then he comes in and speaks with the patient, and then I kind of follow up the end of their infusion.
Okay, great. And then and then usually after the infusion, we'll review their either their labs, their scans, or their need for a cystoscopy if it's bladder cancer, and then we'll make sure that gets plugged in, so that patients may have to have a holiday to get a cysto, they may have to have a holiday to get a scan, and then once all that information's in, we review all of those results with the patient, make sure that we're on the right track.
Yep.
And we keep going.
Sounds good.
Overall, Lauren, would you say that the patient experience is pretty easy? Are patients really burdened when they come through? Are they having a hard time getting through it?
Yeah, I think it's pretty easy, especially because the infusions are only 30 minutes. So I try to get them in and out, at least within an hour, maybe a little bit more if they need labs. But I feel like it's pretty easy, and we try to make the follow-up easy for them as well.
Yeah, and we do maybe 3-4 of these every Friday, right?
Yeah.
And we just use the same room, really.
Yeah, same room.
It's not like we take up
equipment,
or we don't take up a ton of space, and
Nope.
it's not like patients are waiting around forever.
No.
Okay, Awesome. Well, Lauren's a pro. She's been helping us really build and develop this program, and so it's been it's really something that we've realized is very doable in an ambulatory center like this. Great. So you can tell I was kind of fishing for for her to reiterate that it wasn't a huge endeavor. But okay, so we'll finish up real quick with some clinical pieces, which I think hopefully we'll tie some of this together. Gordon and Neil have done a great job talking about the program. And then I'll just touch a little bit on really, I think what all of us enjoy doing, which is having the patient get efficacy, so the actual monitoring of the patient and then the side effects. So the ARS here, and I'm going to move a little bit quickly because I know everyone wants to get out of here for lunch. What is the biggest barrier to managing adverse events of biotherapy? Again, really, and we've looked at this from a lot of different organizational levels in community practice. There is increasing interest in dispensing these and bringing this in-house, but this does seem to be the biggest obstacle. And so within this, what is it that tends to be the most concerning? Is it no formal training, concern with managing patient calls amongst your partners, not comfortable with the steroid piece, perceived amount of time and effort needed, or other? So, so I'll give us a couple seconds. This is kind of the science question that we have to include. So a mini case, which we'll talk a little bit about this at the end. A patient on Pembrolizumab for BCG-unresponsive CIS develops 3 days of fatigue, spreading rash that is currently on more than 50% of his body, and mild joint pains bilaterally. The next step is to hold the treatment and give topical steroids, to hold the treatment, give topical steroids, and initiate oral steroids, hospital admission and IV infliximab, or just to hold the treatment. Okay, so again, last section of this is I think just the piece of what we're actually doing to this patient. And so Gordon talked about pathway and structure, and so I think a big topic or a big thing that's emerged for all of us is, if you're treating this patient, it's not just hitting the button, hitting the infusion pedal on this. You have to understand that these treatments are a little bit different than what we have given in the past, and you have to kind of adjust your pathways, the patient's schedule, the whole process to anticipate what can happen, what can go wrong from both a disease and a safety standpoint. So, just like any treatment we do, just like any surgery we offer, the decision should be based on, efficacy and individualized, really, from a patient morbidity standpoint. And this is a really now common concept in urologic oncology. What are the options? What are the alternatives of doing nothing? What are, especially in the adjuvant space? Neil talked about 2 adjuvant approvals. In an adjuvant space, you're technically disease-free, right? You have a risk of recurrence and a high risk of relapse that may improve with therapy, but you are technically disease-free. And so a high level of side effects or a high level of patient bother can't really be tolerated in those situations. And so, you have to discuss active surveillance or doing nothing with the patient. And it's important to understand that every patient is different, and every patient has kind of a unique therapeutic window of how they can benefit. So I like to call this kind of, thinking like an oncologist. So we're putting on different hats here, but we're starting to kind of think about things in a 360-degree fashion for this patient. And so the things on this slide kind of indicate some of those concepts. Again, not every patient who meets the indication needs treatment, okay? Especially in all of these approved indications that we have, sometimes IO is not the best option for these patients. And that's a skill that I think you obtain after treating patients, after seeing how they respond. Some patients have better efficacy, some patients have worse tolerability. So not every patient who meets these indications needs treatment. And again, competing risks is a really common thing now for all of us uro-oncologists, right, in every disease state. localized prostate cancer, what's your expected life, what's your life expectancy? Are you going to die of something else? And that's still very important here in terms of giving these treatments. Social and family support, I can't even begin to explain how important I think this is in the community. I mean, you're dealing with patients driving, sometimes by themselves, long distances. You're dealing with patients going home, sometimes to empty houses. And part of our intake is, who do you live with? How far do you live? Is this a huge, burden for you to come? We have a downtown, very urban site that pulls from, a pretty big catchment area that includes several rural areas. And so it can often be a big issue. And we are kind of still working on those satellite infusion models. We have a centralized center that does all the infusions. And so that causes some issues. And if I think it's going to be a big issue for a patient, I'll tell them that it's probably best not to give therapy. Similar to how I would counsel a patient if they were having a cystectomy. I'd be much more excited about how that patient's going to do afterwards if I knew they had help, if I knew they had some support at home, et cetera. So the social and family support here is important. And then again, I think, this has really emerged for urologists during APCs, but the importance of non-cancer health during treatment or cancer-related health. So mental health screenings and assessments and understanding how patients are doing emotionally, psychologically, bone health, nutritional support. A lot of these patients have lost a kidney, they've lost their bladder, they have a urinary diversion. These patients have a lot of needs. And frankly, this has been one of the big arguments for urologists getting into this space. While a patient is there, they can be assessed for a urinary tract infection. They can be assessed for a urologic issue. Their stoma can be assessed by the surgeon. These are things that when they go to medical oncology, they don't necessarily get. And so, you try to make it a little bit more of a comprehensive experience for them because, again, that patient or that what has happened to that patient a little bit better. And then, again, kind of thinking like an oncologist, I think, appropriately managing treatment duration and dose. When you first start doing this, you're going to be very, and I think all of us were very vetted to the or connected to the label and to the schedule and to what you think should happen. This patient should get this every 6 months or 6 weeks, and we should do a scan every 3 weeks. Over time, after you do a lot of this, you start to kind of infuse your own experiences and your own kind of expertise into this, and you skip a dose, you skip 2 doses, you get a scan earlier, you get a cysto earlier. That's the secret sauce, as Gordon was saying, is as you get more and more into this, you become the oncologist, you become the treating doctor, and I think that really is a big part of all of this is not being really, we talk about pathways, and pathways are important from an organizational standpoint, but I don't think pathways are really healthy from a very strict standpoint of we've got to get this patient through 1 year of treatment. No, you don't really have to, right? The label on these trials says a year or 2 years or 3 years, but get them through 4 months, get them through 6 months, see how they do. And patients always want to know how much longer do I have to be on this, and you can be very honest. Well, as long as you're tolerating it, as long as it's efficacious, and as long as you're tolerating it, we can keep doing it. But certainly, if that risk benefit breaks down, you can divert off of that stream. So, what we do, and I think more people are starting to do this. Patients like this, we hand patients a schedule. And it's not, and it's funny because I just talked about how I don't like strict pathways, but we hand patients kind of a what to expect schedule, meaning, once we pre-cert and we start on day 1, your infusions are going to be every 6 weeks, and in bladder and NMIBC, you're going to have a telehealth visit every 3 weeks with our mid-level or the doctor, and then you're going to get a cysto roughly every 3 to 4 months. And then that changes based on renal cell, based on post-cystectomy. Sometimes there's scans put in there. So I think that's important because it helps the patient understand what's going to happen in the next year, what are the expectations, and that, I think that helps. And again, this is kind of modulated based on disease state. Do you guys have any thoughts on kind of clinical monitoring? I mean, I'm conflicted on pathways, but I do think something like this helps.
Yeah, I guess my comments would be that I think you have to have a pathway in place, but be flexible enough to kind of modify it along the way for a variety of underlying reasons clinically. But I think what's most beneficial here is to outline what the expected course of therapy is for the patients prospectively. And I think that's part of that initial intake discussion, which can be, tedious sometimes, but really gives them a roadmap of expected kind of schedules, cystos, labs, scans, and also in AE management if they occur kind of along the way. So I think that gives them a landscape, and as things kind of come up, they understand the landscape may be modified appropriately. So
Yeah, I think this is, how's that? Yeah, patients are always asking, well, how long am I going to be on therapy? And I tend to use the three-legged stool example. There's the three things we've already talked about is how are you doing clinically? What are your lab values? And imaging. And we always outline to some degree, like you've done here, like to have a lot of flexibility in it, to your point, because their life gets in the way. A little pearl, and one of the really cool things about IO therapy, unlike chemotherapy, unlike oral targeted therapies, is you do have a potential, and we still are continuing to look at this, is on trials. Yes, you're absolutely right, Tom, as you point out, we try to get patients on IO therapy. It's typically, hoped for 1 to 2 years. But what we do know is that the benefit of the chronic benefit of getting an IO therapy doesn't stop when you stop the treatment. And that's one of the real beautiful things, is sort of the tail of the curve. And I explain that to patients who are on IO, and they actually really like that, as opposed to once you're not getting your chemo and or your AR or your oral or your TKI, et cetera, therapy is theoretically stopping.
So just a couple of kind of technical slides, but just to kind of indicate that this is a little bit different than what we're used to in terms of assessing response and understanding how things are going. And this is kind of pulled from a lot of the medical oncology literature and white papers. But as Neil said, immunotherapy does not exhibit the same patterns of response in comparison to traditional chemotherapy, and there's time-specific differences in terms of how long patients take to mount an anti-tumor response. And not all patients respond the same. And that really does have implications. I mean, if you put someone on Pembro for BCG unresponsive CIS and you see a little bit of disease at your first follow-up, that doesn't necessarily mean you have to bag the whole program. I mean, and that's kind of where the clinical judgment piece comes in. There is, immunotherapy has its own RECIST criteria, which we know from, our trials work. And this modified criteria takes this into account because we actually consider stable disease that actually has shown some increase in tumor burden, which is a little bit odd. But if you have up to a 20% increase in tumor burden, it's considered stable disease, and really the recommendation is to keep going. Now, a lot of this is derived from the metastatic literature or in a metastatic setting, but I think it holds probably the same weight. And then, there's this concept of confirmed versus unconfirmed progression. And so these are two terms that medical oncologists know really well, but it's an important concept for urologists to understand that you can have a slight increase in disease burden, both cystoscopically, I would say, and radiographically, followed by some tumor regression. That doesn't necessarily mean that the patients are failing therapy. So there is a percentage of patients that will progress, maybe potentially initially, because there is maybe a tumor inflammatory process, some sort of systemic response, and then their tumor will get better. So that's why kind of the first scan or the first cysto, if it looks, a little bit worse, usually is not an indication to pull the plug. And then kind of on the other extreme, there is an unfortunate set of patients who are going to really hyper-progress, while they're on therapy. And those patients, you confirm that with, serial imaging, but those patients unfortunately don't have a ton of options. Now, again, this doesn't, it's not like we see this a ton in our non-metastatic spaces, but I think that this biology does kind of apply to our understanding of how we're doing this. So last couple of slides here are the adverse events. A lot of people, again, are interested in kind of how this plays out in the real world, and I think all of us would agree that with some structure and with some experience, this is something that can be done and managed by urologists. As a comparator, if you look at high-grade Clavian adverse events, oral oncolytics and prostate cancer roughly are about 5% of patients that really either have to discontinue or they need to stop. In IO, it's probably in the 10 to 20% range. I think 20% is a little bit high for the localized disease patient, but it's probably in the 10 to 20% range. And then cytotoxic chemotherapy is 40%. And so that's always something I tell patients is that, yes, there are some side effects, but certainly they tend to be more manageable and less, impactful in terms of stopping therapy, having to come off, than chemotherapy. Unpredictable onset and duration of the side effects are the thing that a lot of people are concerned about. You can have patients who have been stable on treatment for a year and then all of a sudden develop something fairly significant. So, that's where the structured monitoring piece has to come in. And then I think the champion physician part of this is important because the physician and the provider, the mid-level provider, need to work as a team to triage these complaints and to be able to handle them. And that's kind of what we do. You saw my nurse practitioner. She's terrific. She'll telehealth visit them, send me a copy of that note. Anything that's concerning, she'll say, well, this patient's having 4 stools a day, more than they were last week. And then we put our heads together and put together a plan. And just like everything else that we do in medicine, once you do it enough, you figure out kind of where to go and what requires treatment, what requires observation. And there's a lot of published guidelines out there right now that can help manage this. And certainly, the overarching theme, I think, is trying to early identify side effects and trying to prevent long-term morbidity. So my staff is kind of tired of hearing me say, don't sleep on a new patient phone call that's on IO. Meaning, if they have a new cough, if they have a new diarrhea, any new side effect that they have not had before while they're on therapy, we should assume is related, and we got to follow up on it. So 3 broad categories of management, and really I think most of us understand that most of these are mild. But if they're not affecting activities of daily life, they're considered grade 1. And the vast majority of the time, these resolve with supportive or symptomatic treatment. An example is a topical steroid for a rash, or something like Lamodal for diarrhea. But most of the time, those things will resolve, especially if the patient doesn't seem like they're missing a day of work or having to force themselves to stay home because of something like this. Moderate toxicity is seen, and I think this is something that if you're going to give this, you have to understand you're going to see this, and you have to prepare for this. So these are patients who actually do have some disruption of their day-to-day life. So their cough is significant enough that they had to stay home from work, or they feel like maybe they're a little short of breath. They're having so much diarrhea that they can't leave the house. So those patients are going to require oral steroid treatment with a taper. And I think one thing that the 3 of us have talked about offline here is the importance of engaging your medical colleagues and not to feel like that is out of bounds, because that's something that is very important here, especially with some of the endocrine side effects that you see. Engaging an endocrinologist, engaging an ophthalmologist, a dermatologist if it's something that you don't really understand. And that's what medical oncologists have been doing for a long time, is having some outlet for someone else to help evaluate the patient, especially when you're first starting and you may not realize if a patient will need something more systemic. So the ability to utilize your medical specialists, I think, is very important, and I think is something that a lot of us who do this well will have kind of in our back pocket. And then severe toxicity, and again, this is something that needs to be expressed to your staff, and the doctors need to know. This is rare. It really is something that we don't see very often, but it can happen, and there are plenty of reports in the literature about it. And this is the patient who just is, feeling terrible, borderline unresponsive. It just says, I'm having so much pain, I don't know what to do. Those patients should be brought into the hospital for multidisciplinary care, which usually, it consists of intravenous steroids, maybe something more significant, multidisciplinary consults, that kind of thing. So sorry, this is a really busy slide, but I liked the messaging. This is from a white paper from one of the ASCO guidelines, and I won't go through everything, but there's a couple tenets here that I really like. Education to the patient and the family about what can go wrong is really important, and so that's one thing our mid-levels do great. And really, if I'm in the room for 5 minutes, I spend 4 of the 5 minutes talking to them about the fact that, listen, don't assume that any of this stuff is normal. If you have something new, you have to call us. Come in, and if you don't feel right, you can manage this in such a way. And a common question that we get is, what happens at 2 in the morning if someone comes into the emergency room? It really, if you've structured the program and you have feedback from the patient and you're contacting patients through their treatment course, that really doesn't happen. I think that's going to happen more in a setting where these patients don't have kind of the understanding that something may go wrong. They're not really monitored very closely. They have small complaints that then turn into big complaints. So patient education is really great, and it's really a tenet even in the medical oncologist's kind of view here. Again, really new symptoms, things that are brand new. So a patient who has not had abdominal pain that all of a sudden has abdominal pain after 2 or 3 courses of treatment, that's something that should be considered significant and brought in or monitored. And again, kind of what we talked about before, hold the ICPs for low-grade toxicities. You don't necessarily need steroids. You just need to give them a holiday from the drug, and then you can potentially get them back on the drug when their abnormality has improved. And then if someone has a grade 4, if someone has a high-grade toxicity and they've needed long courses of steroids or long treatment course, they've had a long issue, don't put them back on checkpoint inhibitors. That's the fundamental bottom line. And that's kind of what's interesting is I think as you do more of this, there's a little bit of a gray area in that too. Is that, there are some patients, and you talk to the medical oncologist and they'll agree, there are some patients that, and their mantra is treat to toxicity, right? They're used to treating these patients until they get sick. That's kind of how they justify, that's kind of how they view efficacy as well. If it's clearly causing something to go on, so we're going to keep it going. Obviously, I think that in non-metastatic disease, we're a little bit more timid about that, but it's still, I think, is something that's going to come out more, is that you can probably get a lot of these patients back on treatment after their primary issue is resolved, but certainly you want to be conscientious of the guidelines at this point. So we're just going to go through 3 quick cases. These are cases from my clinic. I'd be interested to hear what Gordon and Neil have to say, and I think this is fairly reflective of what we see in a high-volume, busy IO program. So this is a 66-year-old female who was on a clinical trial for muscle-invasive bladder cancer, and the trial was neoadjuvant immunotherapy prior to cystectomy. So she was cis-ineligible, so she was starting creatinine was 1.7, and she had hydronephrosis on the left side. After her second infusion, she began to have significant lower extremity edema and fatigue. We brought her in and we got labs. Her creatinine was up to 2.4. She was instructed to hydrate, and we kind of held the infusions. Her repeat check 1 week later it was higher at 3.2 after she'd been hydrating. So she did have, obviously, hydronephrosis, so we said, well, let's just rule that out. So we looked in, we did a retrograde. She had a stent placed on that left side. during the course of the retrograde, we noted, well, this probably is not significant enough to have her creatinine rise like this. So as a precaution, we started oral prednisone, and a nephrology consult was made. And after 1 week of the steroids, her creatinine had come down a little bit. She was feeling a little bit better. We held the next infusion. And so this was most likely immune-mediated nephritis that got better after an oral steroid taper. Based on the verbiage of the trial, the patient had to come off of the trial, and then she underwent radical cystectomy. So any thoughts, guys, on a case like this? I'm sure you guys have seen some nephritis. And nephritis is tough as a urologist because that's kind of where we live, right? We deal with elevated creatinines all the time in patients who have hydro. And so that's why I thought, this case is an interesting case to present, because this isn't urologic renal demise. This is immune-mediated renal demise.
Yeah, you're right. I mean, one of the things I'll say to patients to kind of keep it in a patient language friendly, the lymphatic system, they understand veins and arteries and arterioles, but explain that the lymphatics go everywhere from, head to toe, skin, and all organ systems. And so you can get an itis, an inflammation. Itis is Greek for inflammation. And so you can get an itis virtually everywhere and anywhere. So to your point, always let us know if something's new and different. Nephritis is pretty uncommon. I completely agree with your management here. And that's kind of how, we want the patients to call right away. When in doubt, stop. When in doubt, start oral steroids. And then monitor the patients. And as you did here, it looks like the patient did fine. But given a clinical trial, they had to come off trial.
So the next one's a patient who has M1 CRPC and actually found to have high tumor mutational burden. He had started pembrolizumab and had done well with 7 infusions, so kind of a long duration here. Significant rash prior to his 8th infusion. So again, this kind of shows that this time course is fairly unpredictable. So 7 infusions, which is the better portion of a year, without having a whole lot of issues. And then he had a significant rash. So the infusion was held. The patient was prescribed topical steroids. We did a telehealth visit to kind of look at everything after a few days, and the rash was actually getting worse on topical steroids. So we started oral prednisone. It's a weight-based formulation. And then in 1 week, we brought the patient in, and the rash was improving. Steroids were continued, and then the dose was tapered at week 3. And actually, this patient had a great response on pembrolizumab, and as we all know, there's after a certain point in M1 CRPC, you don't have a lot of great options. So I didn't want to completely deprive him of that. We held it for a couple months, and we got him back on it. And he actually was able to get back on it for 6 or 7 more months until he progressed further. So last case, and I think we're almost just out of time, but this is probably one that is something you don't necessarily want to have happen, but this is something you have to be prepared to have happen. 79-year-old male with BCG unresponsive CIS, and notably this patient probably was one of those people that you look at and you're like, well, systemic therapy for you may have some issues. He wasn't a spring chicken, but he had severe bladder symptoms, severe BCG fatigue, and really was interested in an intravenous therapy when I talked to him about all his options. So he did fine on pembrolizumab for the first 2 infusions, and then prior to the 3rd infusion, he started having abdominal pain. He had elevations of AST, ALT, and his T-Billy was up to 2.5. So, transaminitis, autoimmune transaminitis. We withheld his infusion and we began oral steroids. So after 2 weeks, his AST and ALT now had been rising quite rapidly. He's now at 1,000. His T-Billy was 4. He was jaundiced. He looked like he was getting worse. So I called my hepatology GI colleagues, and I talked to them, and I said, well, should we admit this patient, or do you want to see him? And they said, well, why don't we see him as an outpatient the next day and see what's, what we can do. So they got a right upper quadrant ultrasound that was okay, no obstruction. They continued steroids, again, I think this is where it helps to have kind of seasoned colleagues around you. He called me back and he said, yeah, this sucks, but this is going to get better, but it's just going to take a long time. He said, I don't think he's going to need IV. He's probably plateauing where his LFTs are. I'll see him once a week to check his LFTs, but he's just going to stay on steroids. And so it was quite a long course of steroids. And on elderly patients, when you're on steroids for this long, you've got to think about other things going wrong, right? GI prophylaxis for ulcers, pneumonia prophylaxis, and bone disease. So we kind of had a multidisciplinary kind of meeting about what we needed, and this patient was on steroids for a long time. We ultimately weaned him off. And he's made a full recovery. He's doing fine, and thankfully, actually, his bladder looks good. But this was technically a grade 4 autoimmune hepatitis based on the levels that his transaminases reached. So we had to permanently discontinue. So I think this is a case that kind of illustrates some of those things. You guys have a comment on kind of a more severe case like this?
Well, I would just say that you're going to run across these. They're not the rule, but you will see them. And I remember I was at a program with a very good friend and colleague, a medical oncologist at Johns Hopkins, who said, you know what, I really enjoy learning more and more about IO because it's forcing me to kind of channel my internal medicine chops, and that's true for us too. And I think this is a very illustrative case. You want to rule out anatomical obstruction. I'm sure they may have got a hepatitis panel. And that's okay. I mean, there are, these are patients who are going to have complications in this. So this is not for the dabblers. This isn't a dalliance. You got to be into this. And med-oncs, uro-oncologists, we can work really great with our subspecialty internal medicine colleagues. It's a great case.
Yeah, I think it highlights the need for multidisciplinary collaboration to manage patients appropriately throughout their course. Unfortunately, both to Neil and Tom's point, we don't see this frequently, but when we do, we have to be prepared to deal with it. And I think in robust clinics, which you have the infrastructure, these patients do well if you reach across the aisle, so to speak, and engage the help you have in the community, which oftentimes everybody's ready to help for patient benefit.
Yeah, so that's really all we have. So just kind of to sum up those 3 big points that we had at the beginning, the utilization of checkpoint inhibitors is growing in urology. And I think urologists, either if they're treating themselves or they're not, they need to be fully aware of the roles and the indications. The checkpoint inhibitors can be implemented into a busy urologic practice, I think, utilizing existing personnel, and really have similar needs and resources that your other cancer programs have. It's not something that you need to build from the ground up. And then I think the adverse events are manageable, but really should be thought of as part of a bigger structured program where you're monitoring efficacy, you're monitoring safety, and you're utilizing kind of multiple people to help. So that's really it. Sorry we went over a minute or two, and probably too many slides on our part. But any questions? Or any comments from anybody? Certainly, 3 of us will be around for a few minutes too if you want to come up and chat about something offline. But good. Well, thanks for coming. I think it's cool that the AUA kind of is asked us to kind of do this and is moving in this direction, because I think this is only going to get more and more interesting for all of us in what we do in urologic oncology. So, okay, thank you guys.